for this abstract that we're actually presented here, so we know for amyloid plaques, the renal amyloid proteome is obtained routinely as part of biopsies used for typing, and it represents a relatively unexplored source of information. So what we did was we included all patients that had their biopsies sent at the Mayo Clinic for typing, and these were 2,650 cases that were mostly immunoglobulin-based amyloidosis, followed by ALK2 and AI amyloidosis. And we tried to identify what is the proteome, both the expanded proteome, which means all the proteins that we could identify in these plaques, and the plaque-specific proteome, which consisted of the proteins that were increased compared to normal and disease controls. We identified 498 distinct differentially expressed proteins, and the most common pathways in which these proteins were implicated in was related to the complement cascade. The most abundant, the top 5% most abundant proteins we found were either signature proteins followed by structural proteins such as keratin, such as cytoskeletal proteins such as collagen, followed by serum proteins, albumin, hemoglobin, complement C6, and then lastly by histone proteins. What we then try to do is see if these proteins based on diagnosis differ compared to each other. And we found that AA amyloidosis, AFib, and AAPOC2 actually are quite distinct both to each other and compared to the other clusters. We were more similar. The major drivers of these differences were the more inflammatory type of these diseases. We found increased complement levels, we found increased fibrinogen, other acute phase reactants, we found decreased collagen levels. So the more inflammatory type we see in the clinic is depicted on the proteome too. What we did then was we did the unsupervised clustering and then of all the proteome cases, and then incorporated this to the diagnosis based proteome classification. And we found that AL amyloidosis was quite heterogeneous. It formed 7 distinct proteomic subclusters, which were 3 of them were kappa or lambda restricted, and 4 of them did not have a light chain predominance, which suggests that factors other than the light chain predominance and restriction is responsible and is a driver of the proteomic heterogeneity we see in AL amyloidosis. We also compared kappa AL cases versus lambda AL cases, and we found that kappa cases have increased complement levels, decreased 14-3 family proteins, and in accordance with what we found in the cardiac proteome data, we found increased level of both the total overall proteomic burden and amyloidogenic and signature proteins. And higher level of circulating kappa chains. This is also we found in the cardiac data. And then we compared cases with renal stage 3 disease, again for AL, versus stage 1 and 2. We found increased level of complement proteins, we found increased level of apolipoproteins, and also we found increased level of lactoferrin, a protein thought to be protective for renal pathology diseases. And we found decreased levels of 14-3 family proteins for renal stage 3. For the plaque-specific proteomes, by comparing all the amyloid plaque we had with cases taken from normal kidneys and kidneys with membranous nephropathy, we found that the plaque-specific proteome was quite restricted, consisting only of 23 proteins, which were more signature proteins, followed by acute phase reactants and 14-3 family proteins, and other proteins implicated in renal damage. And finally, what we did was we clustered our case based on hierarchical clustering, and we clustered our cases with available clinical data. We had, of the 2,650 cases, we had 228 with available clinical data. And although we cannot explain every difference here, we found that cluster 1 had improved renal survival, meaning time to dialysis, compared to the other clusters, which was not independent of the renal stage, but still a proteomic signature actually can identify improved renal survival. A major difference of cluster 1, which was the one with improved renal survival, it had the second highest level of total proteomic burden and the lowest amyloidogenic burden. And so in conclusion, what we found is, in concordance to our cardiac proteome data, probably a higher overall proteomic burden is a surrogate of more indolent disease in amyloidosis. Secondly, collagen and complement proteins are the major drivers of differentiation across the amyloid types. And thirdly, AL amyloidosis was proven to be highly heterogeneous, forming 7 distinct subclusters within the same disease. We didn't find this in the other diseases we examined in this study. So the clinical heterogeneity we see is also depicted in the proteomic signature.